back to the second or first panel that we have for today. We're going to be looking at drugs specifically. How did the pandemic affect those who are dependent on drugs? What happened to the drug market during lockdowns? And ultimately how we can move forward when it comes to reforming drug policy. And I do have a full stage today. I'd like to welcome them up one by one. First of all, we have Naomi Berkshine from Harm Reduction International. Welcome to the stage. Naomi, you can take the podium just over here. Following that, I'd like to welcome Pavel Bem from the Global Commission on Drug Policy and former mayor of Prague. Welcome. After that, I'd like to welcome Judy Chang from INPUD. Please come to the stage. And of course, we have Danielle Zolino Geneva from Geneva University Hospitals. And last but not least, for our fifth speaker, we have Antons Mozalewskis from WHO Geneva. And to moderate this discussion, I'd like to welcome Ruth Dreyfus, who's going to be moderating, former president of Switzerland Global Commission on Drug Policy. Welcome to the stage. Now, we do have a very distinguished lineup, so I don't want to take up any more of the time. For housekeeping, we have 60 minutes, and then we'll come back towards the end to close and wrap up if you want to take some closing statements from everyone. With that, I'll let you enjoy the panel.
Mesdames et messieurs,
ladies and gentlemen, allow me to say a few welcoming words in French, and then for practical reasons, we'll have a conversation in English with the members of this panel, whom I would like to thank for their presence today. I would also like to extend my sincere thanks to the Geneva Health Forum for allowing us to come here today and discuss the impact of the current pandemics on the situation of drug users and drug policies. And I would also like to extend my thanks to the interpreters who are here to allow us to communicate. This panel is organized by the Global Commission on Drug Policy. It's a 26-member commission whose members aim to reform national drug policies. In the whole, you'll be able to find our reports and recommendations. Please feel free to help yourselves if you are interested in this subject matter. We have an hour to discuss this topic. The COVID-19 pandemics and drugs. It's an ongoing issue, but it's actually a pandemic that has forced us to look again at the policies that we've had so far on drugs at the global and national levels. The pandemics I'm talking about is the AIDS pandemics, which started in the 80s and in the early 90s. Several countries got together and realized that their policies on drug consumption, which was based on prohibition, was actually making the situation worse and making the HIV/AIDS pandemics worse. Back then, drug users in most countries were the most affected by HIV/AIDS, and were the main cause for the spread of this disease, because drug usage was seen as a crime. When they were hiding, injecting drugs, and they could not have access to services, they were marginalized, and all these policies aggravated their situation and expose the general population to the virus. And so back then we saw the coalescence of two principles, the principle against drug consumption, which was thought to be a solution, coupled with prohibition, as well as public health policy, which shows that as the reason for a new pandemic, and which showed that some groups which were marginalized, vulnerable, were in fact contributing to the aggravation of the problem. Today we are faced with a new pandemic, a different pandemic, which I believe is looked at differently over the past few years. Drugs and drug users have been able to have a voice at the table. They've been able to access care, innovative care. They've been risk reduction and also restrictions of choice. And so it's in this environment that the new pandemic started with its own risk. And because of the various lockdowns that were imposed on these people, they became invisible again, were denied access to services that they used to access before the COVID pandemic. And therefore, we believe that the new pandemics made it even more difficult to keep the gains of the past 30 years. And I think today we think that we need to look at the needs of drug users and not the needs of society in general. And this is what we are going to discuss today. Allow me to thank the members of this panel, and I would like to give the floor to Judy. Judy is very brave. Judy is the head of an organization that gives a voice to drug users. Judy, the floor is yours.
So, just checking. Okay. So the COVID-19 pandemic highlighted inequalities and political fault lines at a global scale, with those most impacted being criminalized populations. Not only were we as a community of people who use drugs more vulnerable because many of us have underlying health issues, but our very status as criminalized, stigmatized, and marginalized populations meant that the impacts of the pandemic and its restrictions were more extreme. Mass incarceration of people who use drugs meant our community was severely at risk in crowded prisons and detention centres, highlighting tensions between public health and criminal injustice imperatives. So early in the pandemic, INPUD, the International Network of People Who Use Drugs, launched a global survey amongst our community. There were a total of 290 respondents from 54 countries who completed the online survey between May to July 2020. So some of the results were that harm reduction services, sometimes the only contact point to health services for people who use drugs, shut down or did not quickly adapt, with over 20% of survey respondents reporting no access to health or social services. In terms of pandemic-related restrictions, homeless people who use drugs were targeted, where 40% stated that policing and use of fines increased overall for people who use drugs. 17% reported that people were harassed or forced into compulsory drug detention centres, forced into rapid detox and incarceration, quarantine camps and homeless shelters during COVID. In some countries, it was complete chaos, where street-involved people who use drugs were rounded up en masse and forced into quarantine centres with no access to opiate agonist therapy or drug services, because authorities had no idea what to do with people who use drugs during a global pandemic. Disturbingly, 43% reported increases in violence, including gender-based violence, from both law enforcement and the general public. So in terms of the drug market, changes were widely also reported. Between 50 to 70% of respondents reported that prices had increased, whilst quality and quantity decreased. Some people either increased their drug use to cope with the mental health stress of a pandemic or decreased due to a lack of supply. Some people switched their drug of choice, and 30% of survey respondents reported problems with adulterants, whilst 10% reported new drugs appearing on the market. In some contexts and countries, this has not dissipated, with the US drug supply reportedly being more tainted than ever before and increased hospital admissions and overdoses. So a central question that we really need to explore is, what happens for people who use drugs when we are dealing with not just one pandemic, but with multiple pandemics at once, including HIV, hepatitis C and TB, and other major emergencies such as the overdose crisis, contaminated drug supplies, invasions and wars, humanitarian crises, relentless natural disasters driven by climate change, etc. What happens to people under such circumstances? How are we expected to survive when we are already highly stigmatized, marginalized, and criminalized?
Thank you so much, Judy. Naomi, I think we need perhaps some word of explanation what is meant under the word of harm reduction, and what are the consequences now of this pandemic on harm reduction measures. And perhaps you could also add what are the consequences of some other crises. I think countries, for instance, who are now closing under the war that is going on in Ukraine just now, closing the services that the people generally had under free institutional order. Naomi, you have the floor.
Thank you, Madam Dreyfus. Harm Reduction International works to reduce and address the negative health, social, and legal aspects of drug use and drug policy. And very specifically say both drug use and drug policy, because it's not only drug use that comes with potential risks, but it's drug policy and a very punitive approach to managing drugs, which causes so much harm around the world. And we know, I think, that it's been an uphill battle for decades, making the point that a compassionate, pragmatic approach to public health and drug use is not only more effective, but is more cost-effective. And beyond everything, it upholds the dignity of the people at the center of the response, helps keep people safe, healthy, and alive. And I think it's been said so many times, it's barely worth repeating it, COVID vastly exacerbated existing inequities. And I think Judy made that point so eloquently, I won't labor the point. People were criminalized for their visible poverty, for their activities, for their legal status in a country, and that really wreaked havoc. Harm Reduction International tracked and recorded there were disruptions to harm reduction services in every region around the world, whether it was a matter of people not being able to get on public transport because public transport wasn't running anymore to access their services, whether it was the fact that people didn't have the masks available to move around, whether it was the service closures and the restricted hours and services scrambling to put in place the right measures. I think this conversation today is so interesting because we can look at COVID and drug policy and drug use from the perspective of how harm reduction services with community leadership stepped up and demonstrated how harm reduction is an essential part of public health and is an essential public health service. And we can also look at the meta lessons here. You know, I think from the beginning it's been so apparent to me and to all my colleagues at Harm Reduction International that there are so many lessons from drug policy that are applicable in the context of a pandemic. We know that a rational, evidence-based public health response considering human rights and the people most vulnerable is what is an effective response. We also know from drug policy that an arcane set of treaties that take an overtly punitive approach to drug use and drug trafficking, and deep investment in securitized responses does not produce safer, healthier communities. And yet in so many cities around the world, like Judy said, you know, governments leaned in to securitize parts of health responses, which is not a sustainable or long-term approach to keeping people healthy. One last point to your point on other humanitarian crises, Madam Dreyfus. You know, our solidarity goes out to the people of Ukraine today. In Ukraine, we saw a phenomenal government, community and civil society response to HIV over the decades. Scale-up of harm reduction services, one of the best examples around the world. And yet, with the crises, all services have been vastly disrupted, and of particular importance is access to OAT, opioid agonist therapy, or methadone. And this is a controlled substance, which means it's a little bit harder to move in and out of countries, a little bit harder to produce in order with regulation, and in the context that the majority of people receiving OAT, or at least recorded on medical records in Ukraine, are men. The fact that men have not been able to leave Ukraine creates a really complex environment for those that need that medicine in that country. That's just the beginning of the disruption to harm reduction services in that crisis. Thank you, Madam Dreyfus.
Thank you so much. We see really that the drug issue is a horizontal issue, that it is multi-sectorial, that it touches all aspects, I would say, of collective life, and that it is also a perfect storm now, mixing different pandemics occurring in the same time and different crises, and the generally the elements that nourish all this, which is poverty, vulnerability, and marginalization. So I think continuing about the services that the people need and can receive or not receive, I would like Daniele to give us the experience we have also in Switzerland to show which kind of solution can be found on the basis of the experience we had, but the new situation. And let us tell also what are the new patterns, perhaps, that are occurring on the health approach and in the consumption.
Yeah, thank you. As you know, since almost 30 years, Switzerland has reformed his offer, mainly also lowering down the threshold, the access threshold to opiate-assisted treatment, not only methadone or morphine, also for medical heroin. And the result of all that was massive reduction, not only of mortality, but also of morbidity. The problem we had the last years was the success of those programs. We had patients who survived and who progressed in age. The mean age currently is more than 50 years, so they advanced in age as we do. What we wanted since several years is to invest more on developing life plans for our patients, to have them more in the city, more in the life. And our programs, the problem for our programs was that there were some rules making that they had, for example, the heroin prescription program to attend twice a day. The fear we had with the beginning pandemic was a drying out of the market. So the idea was to have the most even lower threshold, and we collaborated with another structure, the consumption rooms. But at the end, what was seen, there was no change of the market, enough heroin, but we had the problem of the social distanciation, of the physical distanciation in our facilities, and there we had to negotiate with the Federal Office of Public Health. And at the end, what was possible is to space the attendance from twice a day up to at the end even once a week. So the pandemic finally helped us to reform what we wanted since almost 20 years.
Thank you, Daniele. I go to Pavel now to give us perhaps a more comprehensive view from your experience. Was this pandemic something that helped to progress in some issues, like those who Daniel was just showing, or showing also that the over-incarceration of people who use drugs is just fueling not only this pandemic, but many others and many problems, and that it is not the adequate response? Or is it, on the contrary, a backlash in the policy that was developed in the last 20 or 30 years? Please, Pavel.
Thank you, Madame Dreyfus. Pleased to be here in this panel. Maybe you remember mantras: stay at home with your close relatives, get out only to get to your employment, or in cases of emergency. Actually, my country is the Czech Republic, so this was just the major governmental mantra and mass media and social media mantra: stay at home with your relatives. Well, I'm a psychiatrist, medical doctor. I spent all my life just advocating for harm reduction strategies or pragmatic public health oriented strategies to deal with addictions or substance abuse problems. And I have deep concern for those who have no home, who have no roof over your head, who have no relatives. And this is the case, and it was the case, and still it is the case of many, many people who use and especially inject illicit substances. So when that happened in the Czech Republic, it was probably the end of April or maybe beginning of May 2019. As a member of the National Drug Commission, I called to Prime Minister asking him, well, could you give me 2 minutes of your time? I would like to share with you my concerns. And he said yes. And I asked him how those with no homes and with no relatives can fulfill your recommendations or even the rule of the law, because it was based in the Czech Republic by the law. So when I try to respond briefly to Ruth's question, it comes to my mind that it's extremely difficult to judge and just to make sort of a evaluation, really good evaluation, even based on the evidence, on the data. And I spent all my life just trying to collect the evidence. When I was a mayor of Prague, I was collecting the evidence on the use of various substances, and I was trying to do my best in order to provide and guarantee the access to services. What I've seen in the Czech Republic are two different perspectives. The one is what has been already said by Judy and by Naomi and by Danielle, is just the decrease or even a lack or zero access to health and public health and harm reduction services, even in the Czech Republic, where the harm reduction is one of the key pillars of the state policy. Certainly, I've seen that these vulnerable and marginalized groups are even more marginalized and stigmatized. I've seen the disruption of the markets, as has been already noted, shortages, cuts, replacements of various substances on the market, sometimes with lower potency, sometimes with higher potency. So all these changes in general creating a mess in heads of our clients or in heads of people who are using drugs, thus putting them at risk. I've seen the budget cuts, and even when the extra funds for dealing with the COVID appeared from the national budget or from the city budgets, for example, I've seen the disproportionate extra funds distribution. For drug users, no. We have different priorities. But on the other side, the other perspective is that on one side, is it okay? Yeah. On one side, we've seen the enormous flexibility of black market. On the other side, I have seen the enormous flexibility of civic society movement and harm reduction services. Emergence of new services. We created COVID areas, provisional outdoor shelters for those homeless people using substances with no homes, being on the street. I remember the empty city, and the only people in the city were homeless people. It was unbelievable. I don't know if you have the similar or the same experience. So the extra or new services which have been introduced as a result of this public health crisis are still existing in my country. So the provisional outdoor shelters with comprehensive care. Some of our clients for the first time received a psychiatric treatment, or the serious and responsible treatment of comorbidities, somatic comorbidities. New OST regimes. As we know, there are some barriers. If you want to use a methadone or buprenorphine, well, you cannot use other substances. If you use other substances, you are kicked off the service. Well, suddenly, there were just this easing of the provision rules, which are still in place in the Czech Republic. There are home-take naloxone programs, never been in my country, unfortunately. Now it's there. There is online service provision. This is interesting. Our clients, they do not have the internet, so they are not online in any sense. But we were able to ensure that, for example, the GPs, practitioners, and specialized physicians were providing the online somatic comorbidities services for our clients. So in fact, in reality, it made an enormous shift in the process of destigmatization, because they started simply, the GP started simply to treat our clients. So conclusion, on one side, I am absolutely aware of the negative effects of this public health crisis. But on the other side, at least in my country, I've seen enormous challenges and opportunities, and I am really happy of that. And the final statement is that we introduced for the first time in the Czech Republic something which we called uliční medicína in the Czech language. That means street medicine. Street medicine. What can we do with our clients being on the streets, on some semi-hidden spaces, drug flats? How can we just provide them with the medical support? Okay, street medicine is the answer. So I'm quite optimistic. Thank you.
Thank you so much. Anton, before we go to these forces that were described, to forces of change and adaptation, I would just like to ask you, from the knowledge WHO has about the drug issue and the pandemic, and these multiple pandemics that are touching the people who use drugs, do you think that there was an increase? Could you watch an increase, for instance, in TB, in AIDS, in hepatitis, because of the lack of treatment due to the COVID pandemic and the measures taken? Or do you think that the situation in the country perhaps was a better acknowledgement about these different issues that are coming together, especially on this vulnerable group?
Yeah, thanks, Ruth, for the question. And you rightly noted that it's not very simple, so it's a complex. So that definitely there might be pros and cons. Pros, that maybe there is more attention to public health and epidemiology and infectious diseases. But speaking about the possible change in the trends of infection, we cannot say with confidence because the routine surveillance systems, they cannot show so quickly the change in the, especially HIV, but also hepatitis, and we don't really have very good data system for hepatitis. But what we could see, and what WHO and many other organizations were able to monitor, that was the decrease to access and the coverage of interventions for testing and in some cases treatment and prevention. And we recently conducted a survey or like a review of all surveys that were conducted in the European region for the services related to HIV and viral hepatitis. And we could see that particularly testing was affected, so we lost in case finding during the pandemic, so definitely there will be consequences for that. And for treatment, luckily, HIV treatment programs, they were more stable in most countries, so unfortunately, but also we understand that interruption of HIV treatment is much more risky and serious. But for hepatitis C, we could see that on a global level, the treatment coverage or treatment initiation of hepatitis C has decreased more than by 50% in year 2020 comparing to the previous year. So, but on the opposite, the prevention services, particularly where they're provided in the community-based services, of course they also were affected, especially in the first wave of the pandemic, but they were more flexible and they were more resilient. So this also shows the importance of engaging the community-based, the community-led services in providing also services for infectious disease hospitals. So to sum up, definitely we will see a pushback in our own goal for elimination of hepatitis C and also in reaching HIV. And now we have to see what we can do to catch up with what has been lost, maybe to scale up this innovative intervention that were mentioned by by Pavel, and particularly also some innovative service delivery models, telemedicine, and also in regard of opioid substitution treatment, take-home dosages, which was introduced for the first time in several countries in Eastern Europe. So definitely we have to take the good lessons and continue.
Thank you. Let us speak now about the forces of change, the lesson learned from this pandemic, even if it is not finished, but I think the 3 years have learned us a lot also about changes, necessary changes in drug policy. So I will continue with you, Anton, because the UN plays a very important, the UN system plays a very important role in the drug policy. I mean, the 3 conventions that were adopted in Vienna and are the most influential tools the UN developed in drug policy. And in our view, these tools do not take into account in a sufficient way the lessons of that prohibition is fuels pandemic, and that it is difficult also to speak about the drug issue as a pandemic, which was at the origin of this discussion that were brought internationally. It was considered as really the threat and the scourge of humanity, and the measures taken were mainly this prohibition and repressive approach, which we know now that they are fueling the pandemic and that they are in opposition with a real public health strategy. So there were changes also in the UN family. On one side, we had in the year 2016, the General Assembly, Special General Assembly on the drug problem. And this was a first step to consider, I would say, public health approach, human rights approach, evidence-based approach in the drug policy in a way that was very important. But this was a resolution. So we have to think about what happened on the ground and what happened in the UN family. Are they still silos? Is it still so that what is decided in Vienna has not a lot to do with what is decided in Geneva, for instance, mainly in your organization, in WHO? And there, I would say there was a second very important step, and the very important step was that the UN adopted a common position on drug in 18, which oblige, in principle, all organizations of the UN family to work together and to overcome this partial view of each agency and organization. Well, in this picture, what is WHO making? How far can WHO in the whole family, on the international level, but also in the activities on the national level, where you help countries to build health system, really be online with this common declaration?
Thank you. The document that you mentioned, 2018, that was the joint UN system position. So it did not go through the political process. So it was not kind of discussed by the member states. So it was a kind of a internal UN, not internal, but I mean, was aimed to the UN, different agencies, as you mentioned, to harmonize our view and our opinion on how the drug issue should be addressed. And it definitely was a very important step on the way to harmonizing our what we are saying and what we are doing also, and how we're supporting member states. Actually this joint common position includes and actually is based on WHO guidance and recommendations that were made before this position. So actually this was like to bring WHO recommendations which are evidence-based and which actually spoke about harm reduction and about the effectiveness and the evidence-based of harm reduction already before that position. So I think, in fact, WHO was the first UN organization to speak out on harm reduction because it was easy, because it was evidence-based, and oral WHO recommendations are evidence-based. And in 2014, WHO published the key population guidelines, which have not only health sector intervention, but also so-called critical enablers that include also fighting stigma and discrimination, revising the legislation. So it basically calls for decriminalization of drug use and possession and other behaviors of key populations. So this actually, I mean, this our mandate to generate the evidence and also to work with other agencies to align our position. Maybe also to say a few words that now we are developing the updated global health sector strategy on HIV, hepatitis, and STIs, which should be adopted by all member states during the World Health Assembly in a couple of weeks. So, which also is based on the WHO evidence-based recommendations. It also has a specific strategic direction in improving the legal environment and changing the discriminatory laws and also addressing criminalization of key groups. So I think we are on the right way, and I think that there will be progress, hopefully.
Pavel, we feel that there is a distance between the decision taken in Geneva at WHO and the political decision taken in Vienna, where the member states are coming together and they have the decision-making power, for instance, about the list of substances that are prohibited and the consequences that the convention has on the national legislation. Can you tell us a little bit more about which forces also can help to change this this axiom of prohibition that is the axiom in Vienna?
I think, Ruth, you said it very softly and nicely. And I'm afraid that there is not only a distance, but sometimes there is a wall. And sometimes what is agreed here in Geneva never reached in reality the space and time of decision-making processes in Vienna. So based on that, and for me, pandemic really even highlighted more the phenomenal discourse between two major philosophies or paradigms. That is the one on drug policies, which is based on harm reduction or public health and respect to human rights, and the other one is just based on the repressive drug strategies, incarcerating the people with no effects on that, and with enormous human cost, but also economic cost for the societies. So I think when we look at the challenges for the future, what we have learned during these 2 years, for me it's clear that we, much more than any time before, should advocate for the fundamental shift or transfer of the mandate of INCB and the UNODC to World Health Organization to really guarantee not only the, let's say, harm reduction services for people who use drugs, but also to ensure that the essential medicine painkillers for pain relief are accessible for billions of people around the globe. So for me, I think to change the reality and to cut the distance or just make it really in a pragmatic sense working in the grassroots, in the field, we must simply work and push from the political perspective with the mandate of World Health Organization and just to make the voice of WHO much, much stronger. And it's also very much linked with the classification of substances which we know that for a long time, and we somehow get used to it, but which are really not based on the scientific evidence. And the WHO is the institution, an UN agency, which should be and is responsible for that and should have the mandate to really introduce that in a real life within our national drug policies, but also within the international drug policy framework based on the UN conventions.
Thank you. Thomas, do you want Anton, do you want to answer on this? Or do you have, because WHO is directly mentioned as the hope that evidence will play a greater role in the future also for the whole policy, not just in Geneva, but in the system, in the control regime at large.
No, I only can agree with Pavel, and also have to say that in WHO we also have different teams and working on infectious diseases and harm reduction, and the other team is working on the substance use and dependency. So I think it's also a good sign because we are trying to align our message also within this team and also to address the drug problem in a more unison way, and also to speak with UNODC and also have a better relationship with UNODC and more working way. So yeah, I only have to agree.
Thank you so much. Yeah. Naomi, speaking about lessons learned and the forces for change, you have an overview about what the different countries have introduced as harm reduction measures. Where do you see the forces for change in action?
Thank you, Madam Dreyfus. Also, responding to this very interesting discussion around the role of WHO, I think, we are at the Geneva Health Forum, but it's also important to acknowledge that not all drug use requires a health or a medicalized response. There is a huge component of drug use that needs a robust health response. We know that's far preferable to the criminal justice response. And I think that there are huge opportunities in the fact that, drug use is complex and multifaceted and driven by different reasons. There's huge reasons for WHO to step up and show that leadership and take a more present role. Particularly, you know, drug policy is discussed at the UN General Assembly in New York every year. It's discussed at the UN Commission on Narcotic Drugs every year. It's discussed at UNAIDS in the form of harm reduction. And now it's increasingly discussed at the Office of the High Commissioner for Human Rights, OHCHR. So I think there's a real opportunity to seize the fact that there are so many people, so many institutions with a say, with important information and data and drive to engage in and improve our response to drugs globally. And I think it's about taking advantage of the fact that there are all these institutions, including WHO, that can take a more powerful presence in deciding the future of drug policy. I think that's kind of one of the important forces that we grapple with, particularly in the past 2 years, as we've seen how virtual access has made it much easier to step into a forum like this, or step into the UN Commission on Narcotic Drugs, or step into a New York fora that we might not otherwise have had access to without a plane ticket. I think, back to those trends and the forces for change. I think, and another really important thing for us to be grappling with in public health and drug policy is around political will and investment. And I think we can't go by this because it's such a difficult thing for politicians to kind of turn the ship and recognize where they need to be investing their money. We know that there's about $100 billion spent on drug law enforcement every year, which is more than 750 times the amount spent on harm reduction services. And drug law enforcement does not improve community health and safety. It does not improve human life and human dignity. You know, it puts people away. And we also look a lot at prisons and, you know, health and harm reduction services in prisons. And they're still vastly lagging behind the harm reduction services in communities around the world. And I think that COVID has really shone a light on places of detention as well. We need to use that momentum to continue to scrutinize health practices in places of detention. So, for example, you know, at the beginning of the COVID pandemic, there was a lot of talk about prison release schemes, decongestion schemes, getting people out if they didn't need to be there. And in the face of this fantastic public health initiative, you know what like 20% of countries did? They said, oh, but it doesn't apply if you're in here for drug offenses. So it's this constant clash of ideology and evidence-based public health, which is difficult. Equally, a year and a half later, in the pandemic, we saw that 120 countries had started to roll out vaccination programs in prisons, but only 20% of those countries had reached 80% of all people in prisons. So again, there needs to be greater demand for scrutiny for ensuring health in places of detention, particularly because so many people are locked up for drug offenses and for drug use. I'll just finish that point by saying, pre-pandemic, we were already in a lot of trouble with harm reduction. UNAIDS says that we need $2.7 billion per year by 2025 for an effective response to HIV amongst people who inject drugs. And we know that health and drug use is much broader than that parameter, but let's use that figure. In 2019, we had 131 million funding harm reduction services around the world. That's 5% of what we need. And so we started with an abysmal place. We started in an abysmal place. And any crisis, whether it's a humanitarian crisis, the Russian invasion of Ukraine, a pandemic, it causes governments to shift and divert funds, often in a way that helps marginalized populations, but often in a way that leaps so suddenly those marginalized and criminalized populations get left behind again. So I think it's incumbent upon all of us as public health practitioners to understand and to track the fund flows and insist the money is being invested for harm reduction. A really important thing coming up is the Global Fund replenishment this year. The Global Fund provides 60% of all funding for harm reduction in low and middle income countries. If we don't have our major donors like the UK, Germany, the US and France step up to their pledges, harm reduction services will be further cut and decimated. Thank you, Madam Dreyfus.
Thank you. Judy, among these forces of change, there is a civil society, but there is one group more than all others, I would say, and that is a group of the drug consumers. They articulate their needs, and this is a new phenomenon. I mean, for me, as a politician in Switzerland who has helped to develop the reforms we know now, nothing would have been possible without the voice of the people who are directly concerned, their families, their relatives, and so. So you are really representing one of these forces of change. It needs more bravery than for others groups, because on the general criminalization of the consumption, you put yourself in danger when you take the floor and you speak loudly. What are your needs? What is your life? Who you are? Why you have the exactly same rights than all other people in the society? Tell us more about the force of this movement worldwide.
Yes, so I mean, the movement for change from people who use drugs is really based on two fundamental issues and concerns. So one is the full realization of rights, to recognize the inherent dignity of people who use drugs worldwide, that we don't cede our rights simply based on the fact that we use and consume illicit substances. I think the second point that we really push as well is the recognition of the importance of community-led responses, that, you know, in all discussions to do with drug policy reform and harm reduction, to do with our lives, you know, people who use drugs should be at the center. And I do think with COVID, you know, at the beginning of the pandemic, we really did also push to see this as an opportunity and really kind of link our push for rights and for community leadership, you know, back to some of the lessons that COVID exposed. And I think there is an opportunity for this. You know, I think what COVID-19 pandemic demonstrated, that relying on health systems is not enough. That criminalization and the 3 drug control treaties and drug criminalization around the world in different countries really drives and creates inequity. And we saw during the pandemic, where inequities were high, that viral transmissions amongst the general public cannot be suppressed using social restrictions alone. You know, people were really being forced to make impossible and really difficult decisions between their basic needs and rights, such as being able to, the right to food, income, security, and clean water, or risk transmission. And we also found that the level of compliance with social restrictions, unsurprisingly, are lowest amongst criminalized groups. And we really need to, you know, look at health within the bigger frame of rights and dignity, which means that in order to achieve a healthy society, much more needs to be done and considered beyond the health system. So decriminalization of drug use and possession is a way to ensure that people who use drugs can obtain their rights. In this case, protecting ourselves against a pandemic, whether it's COVID-19 or potentially something worse in the future. And it really depends on whether we want to make sure that all of us are prepared for incoming threats, or whether we continue to choose to handcuff some of these groups and some populations. Because I think what COVID taught us at a moment where we all felt universally vulnerable at the same time is that no one is safe in a pandemic unless everyone is safe. And secondly, just about my point about community-led responses. You know, COVID did expose the fragility of health systems. It showed that they lack flexibility. They cannot adapt in real time because they are designed from the top down, and they respond to pre-identified specific health issues. So drug user-led organizations play an important role in reaching those who are unreachable, especially in times of crisis. So when we break down what the term pandemic preparedness and response means, a term I'm sure we're all getting very familiar with, when we try and break down what it is, it really hinges on community system strengthening. So the harm reduction in drug users movement provides an opportunity for health systems all over the world to extend their reach and truly reach the last mile. So investing in harm reduction and the drug user movement is not only an investment on issues related to drugs, it's an investment on systems for health overall. So I really hope that, you know, this lesson is taken on going forward. I think, you know, the other speakers have already talked about some of the progress. We are concerned that some of this progress is rolling back. But, you know, the best way, just to end, the best way to ensure preparedness for whatever comes next is to make sure that we are treating everybody with dignity and respect always, and not to roll back the small progresses that have been made during COVID, but rather to keep moving forward and building on these.
Thank you, Judy. It is clear that COVID can be a chance. The pandemic can show what really in this millennium public health has to be. It is not a matter of constraint. It is not a matter of criminalization. It is a matter where you have to consider in the meantime the population as a whole and each individual with his needs and with his special situation. Because, I mean, the history of public health is a history with a lot of constraint also. And in some cases, the discussion is still alive. I mean, the vaccine obligation or the mask obligation, these were discussions that brought also to the ethical problems of the individual rights and the collective rights, and the balance that has to be found. In the drug policy, there is no balance of this kind because the repressive side is dominating the public health aspect and the needs of the individual. And I think this lesson and this thoughts that can bring to us the experience of COVID-19 and a real epidemic that has nothing to do directly with drug consumption, as it was in the past with AIDS, where this group was especially on threat for themselves and for the whole society. I think this will help us, in my view, to find a real new definition about the human rights in the fight against collective problems. So I think we have just reached the time to finish this panel. I am sorry that we had no possibility to discuss with, but I see one hand, so please.
Yes, thank you. Thank you very much. Just I want to raise about the tripartite dialogue between WHO, WTO, and WIPO. I want to ask you, because this challenge, it is about patented drugs. But anyway, this tripartite meeting, annual meeting, it could be also, we can also discuss with your own organization about those drugs without being patented. So the next General Assembly and the next meeting, I want to hear you a few words about that. But I have another question, please. Yes, about cities, because just before pandemics, we setting up in Geneva, the Geneva Cities Hub, the hub of cities all over the world, and leading by the former mayor of Geneva City, Sami, and as the former mayor of Prague City, what you can tell us about urban health in Eastern of Europe? Yes, as you said, criminal groups and those, but nowadays promoting urban health in Eastern of Europe, in Prague, in Bratislava, Budapest, Warsaw, and as your own experiences. And you are welcome for Geneva Cities Hub. We will also improve this aspect for the future. And the regional office of WHO is located in Budapest, yes.
Please.
Thanks for the question. I have to say sorry. I didn't really get because of the echo. Can you repeat?
Yeah, the tripartite meeting between WHO, WIPO, WTO, it is about patented drugs. But anyway, those drugs without being patented. Yes, we can improve public health on this issue with your own organizations. You reach or no?
Well, it's...
You are not aware about the tripartite dialogue.
Let's Pavel begin with the problem or the chances also of city policies in the field of drug issue. We have, I think, a report, perhaps it's here, or it can be also asked in the Global Commission on this special issue. Pavel?
Yes, I totally agree with you. Thanks for the question. Actually, I think we have to look at the examples of a good practice. The imperative of public health is that we protect the public health of society through protecting the individual health, through providing needles and syringes for injecting drug users, We are just protecting the health of the society, as an example. And similarly to the need to look at the countries which are progressive and to group them within the UN system and create a coalition of these countries, and through this power we can change the general UN framework, the absolute necessity for the pragmatic aspect of the good drug policy implementation, delivery on the grassroots level, is that the cities has to be involved. And we see phenomenal examples in Switzerland, Zurich, Geneva, and we see good examples in many other cities, not only Prague. And we are trying to group together and generate the power and to learn one from each other what is the best practice. Because, for example, COVID showed us that the repressive drug policy states absolutely failed to access the most vulnerable from the HR, harm reduction or public health perspectives, target populations. So among the homeless people and people using drugs in the repressive-oriented policies of states, just the COVID has been spreading so fast. On the other hand, the good example of a good practice from cities where the policy is progressive and looking at the reduction of the harms and at the public health services delivery, we show that there was almost no or zero difference between this marginalized group and the general population. And this is, for example, the case of Prague. So I think grouping the cities and enforcing them and empowering them also, because even though the national legislations are repressively oriented, penalized or criminalized the possession of drug use, still on the city level, we can do a lot. So I would say we have to decriminalize, as it has been already stated, but at the same time, we have to look at what people using drugs need. And it's easy. We know that. So I thank you for the question, and I agree with you that cities have the power and should play the role.
Big thank you to Pavel, and also thank you to Ruth for moderating this discussion, and also to all the panelists. Also to the audience, if you've witnessed, we did have an incident, but I want to share some good news. Daniel is all well. He's been treated by a doctor right after. Good thing that we are at the Geneva Health Forum, and he's just resting outside right now. So just wanted to share that update. And thank you to all the panelists once again, and moderator. Thank you.